All right, so we're going to cover a number of nervous system disorders. We're going to start here with anxiety, and then we'll also talk about depression, bipolar, psychotic disorders. And so what you're going to see is a lot of overlap in terms of drug classes, mechanisms of action. So a lot of these drugs are going to be in the same family. And so I'll try to go through and describe the mechanisms, and then later on, maybe I won't have to describe them as much, just more of a review kind of a thing. So to start with anxiety, most of us have an idea of what anxiety is. I mean, we feel anxious about things. And in general, anxiety is useful. If you feel anxious about an upcoming test, you're probably going to be in better shape for that exam than somebody that isn't worried about it at all. Um, some level of anxiety usually helps us prepare. It gets us ready. Now, anxiety as a disorder is usually, and I have here, to be a disorder, it must be pervasive and interfere with normal activities. Okay, so that's where it kind of separates into a disorder, and we're not going to get into all the diagnostic criteria, but that in general is what we're talking about. So if we just define what anxiety is, it's chronic fear, worry, or unease about an imminent, so that means something that's coming up and is going to happen, or something with an uncertain outcome that is, and here we go again, out of proportion to the actual likelihood or impact of the feared event. So being concerned about an exam coming up is normal as long as it falls within that normal range. Okay. So I have a number of them listed here. Generalized anxiety disorder, feeling anxious on most days, lasting longer than 6 months. Most of us feel a little anxious on most days, maybe not. I guess in nursing school you probably do. Panic disorder, brief but overwhelming fear, terror, or impending doom recurring over a period of 1 month. And a lot of times these may only last 10 seconds or something like that. But the heart rate goes up, you start sweating, you start hyperventilating, so shortness of breath, fear they're having a heart attack. So you have a real, genuine physiological type of response with a panic disorder. Phobias, irrational fear about an object or activity, going to great lengths to avoid it. A lot of people have phobias about injections, going to the dentist, but it's really whether it impacts your life. I mean, I think everybody is a little bit scared of spiders and snakes, but once you look at it and you realize you're safe, you're okay. Other people, jump up on the counter and scream and are pretty much paralyzed by it. Okay, so social anxiety disorder, fear of being criticized, embarrassed, or humiliated, even in everyday situations. And one of the examples I read was such as being assertive at work, making small talk. So again, everybody's a little bit uncomfortable maybe with those situations, but it's when it prevents you from sometimes leaving the house. Obsessive compulsive disorder, or OCD, unwanted intrusive thoughts, usually acknowledged by the patient to be irrational. Okay, so a lot of people say, oh, I'm really OCD, and because you have your notes color coordinated and sectioned off and everything has to be in the right place. Well, a lot of times that's just being really well organized. And maybe it's sometimes difficult to see the difference between being well organized and having OCD, but again, it would be where it's irrational, it's too much, and it stops being helpful and it starts being harmful. So for example, fear of germs may cause excessive hand washing to the point of cracking, bleeding skin. Now, wanting to use hand sanitizer a lot is probably healthy, but yeah, if you have cracking, bleeding skin from washing your hands too much, then maybe that's a problem. PTSD, post-traumatic stress disorder, follows a traumatic event, assault, war accident, something like that. Symptoms can be maybe difficulty relaxing, bad dreams, flashbacks, avoidance of reminders of the event, and it usually lasts at least a month. So one of the other things is that a lot of people that came back from like the Gulf War or something like that, it was years before they realized that, okay, this is a PTSD event. And a lot of people who were abused as children, they may be an adult before they're finally able to kind of face that and realize that it has been intrusive. All right, so the brain, what's going on in the brain? Hopefully you remember this term, the limbic system from physiology. The limbic system is it's not a brain region, it's a whole bunch of brain regions. It's a whole bunch of brain structures, okay? And it's responsible for emotional responses primarily, but also learning, memory are mixed in there because of the hippocampus. But we're gonna talk about a couple of different things. So to kind of set a scene, what happens is let's say, to use an easy example, you see a spider. Okay, you look at that spider and it looks a little creepy and crawly, and so your amygdala will be activated, and it's going to set off a chain of events. It's going to activate other regions. There's some listed here: striatum, hypothalamus, prefrontal cortex, and we'll get back to the prefrontal cortex. But that amygdala is really involved in fear and anger, and a lot of people with anxiety have an oversized amygdala. And so it's harder. So when that fear response happens, it overactivates and it causes too much activation. Well, you have this other brain region called the prefrontal cortex. It's supposed to be logical. It's supposed to be able to think things through and say, okay, look at that spider. It's, it looks half dead, or it's, obviously just a spider that's out looking for bugs. It's not, poisonous, or I guess venomous is the word. So your prefrontal cortex can kind of override that and say, okay, just calm down, don't worry about it. Okay, so obviously we can see a couple of areas where that can go wrong. Neurotransmission from the amygdala says, oh, it's a panic situation. And then if your prefrontal cortex can't calm you down, then there's a problem. Okay, so sensory information passes through the thalamus to the amygdala, which results in a fear response, passes signal to other nearby regions. The prefrontal cortex is supposed to shut it down. So if we really think about what's going on, there are a whole lot of neurotransmitter systems involved in regulating that process. Okay, so when something seems scary or makes you nervous or makes you anxious, then there are a number of different neurotransmitter systems that kind of take care of that. So I named a couple of them here. And I only did this, I named these because these are the ones that we're going to see drugs, that drugs primarily have their effect on, also dopamine. But GABA is an inhibitory neurotransmitter. It's going to kind of shut everything down. So that amygdala, when it activates, if you activate inhibitory interneuron or inhibitory neurons, then you're going to kind of just shut everything down, and that's going to calm you down. Okay, so that's why a lot of sedatives are work by activating GABA receptors. Serotonin, we've heard a lot about serotonin in terms of like maybe as an antidepressant. And so antidepressants, these serotonin pathways are somehow involved in this anxiety and mood type of response. Norepinephrine is also involved. And we don't know exactly, we can't point to this pathway and say it's this pathway and this receptor, but we do know that the drugs work and we can see those connections. So that's about as far as we are right now. So also a couple of other things: a sympathetic response, epinephrine, and this, remember epinephrine, adrenaline, the fight or flight, stress hormone cortisol, they're also activated, and then dopamine, glutamate, acetylcholine, lots of different neurotransmitters. You're talking about the brain. All these regions just kind of communicate with each other, and so you have a lot of transmission that happens. Okay, so first of all, we have to look at non-pharmacological therapies to cope with anxiety. So any patient that's exploring the cause, or well, should be encouraged to explore the cause. So if they are exploring the cause of their anxiety, okay, that's probably a bad way to say it. They're encouraged to explore the cause of their anxiety as well as seek non-pharmacological treatment. So if you can remove the threat, that's a good thing. But if they're just trying to figure this out in the beginning, they should probably try non-pharmacological treatments first, like counseling and then cognitive behavioral therapy, which is similar to counseling, except you actually try to change your behavior and change your thought patterns. Biofeedback, where you kind of monitor your own heart rate and breathing, and then learn to control that, which can calm you down, and then meditation also. Okay. Anxiolytic. This is a term, and I define it right down here. An anxiolytic is a drug having the ability to relieve anxiety. So that's what we're really talking about. But when we talk about, so let me I'm going to kind of go in the wrong order here, but Anxiolytics have the ability to relieve anxiety, sedatives sedate you, and hypnotics can induce sleep. Okay, so what we're talking about here is depression of the central nervous system overall. Okay, so we have this term CNS depression. So it lowers activity of the central nervous system, and it is a continuum ranging from relaxation, which might be anxiolytic or might be anti-anxiety, to sedation, to the induction of sleep, and then all the way into anesthesia. Okay, so that's what a lot of these, especially the benzodiazepines, can do. So anxiolytics, the idea is that you take the drug and it relieves anxiety. Okay, you don't necessarily want to be, you don't want the patient to be sedated necessarily. You want them to not have the anxiety. Go a little bit further, sedatives, due to their ability to sedate or relax a patient, that sometimes is necessary in like an acute situation. Ativan. Hypnotics, because of their ability to induce sleep. Okay, so that's going to make the patient sleepy and well, put them to sleep. So we call that a hypnotic, not like hypnotize. You're not hypnotizing the patient. That's putting them to sleep. That's what hypnotics do. So these can all be the same drugs, but at different doses. And so you can have an anxiolytic effect, and then a sedative effect, and then a hypnotic effect. So most central nervous system depressants can cause physical and psychological dependence. So that's what we're talking about here is CNS, central nervous system depression. Can have physical and psychological dependence, so they can get hooked on them. May also cause respiratory depression at high doses, memory impairment, so retrograde amnesia, or impairment and then retrograde amnesia, confusion, oversedation, can't wake up the next morning. So they do come with side effects, which is another reason why, you know, the ideal situation would be to use a non-pharmacological approach. Okay, so here's that term again, anxiolytic. Remember, lysis means to cut, anxio refers to anxious or anxiety. So an anxiolytic is going to relieve that anxiety. It's going to cut or cleave that anxiety or reduce it. That's the idea. So quickly to go through these, because we're going to go through these individually. Agents used to treat anxiety and sleep disorders can be categorized into 4 classes. The benzodiazepines, which are CNS depressants. Okay, so they have a sedative, hypnotic, and anxiolytic type of effect. Alprazolam or Xanax is our prototype. Barbiturates is a CNS depressant, almost never used, and we don't have a prototype drug for it, even though we're going to talk about what they do because we have to. And antidepressants, or in this case, we're going to talk about selective serotonin reuptake inhibitors, and that's paroxetine or Paxil. And then atypical anxiolytics and hypnotic drugs, and they're called nonbarbiturate and nonbenzodiazepine, which is why we're going to talk about what barbiturates are. But these are kind of an unusual atypical category. And buspirone or Buspar is the prototype for that. So let's first of all talk about benzodiazepines. Here are some examples, and to get the naming kind of down, alprazolam, that's the prototype that we're going to talk about. That's Xanax. Diazepam, Valium, a lot of us have heard of that. Midazolam, Versed, which is called Versed. Lorazepam, which is Ativan. Benzos usually end in lam or Pam. So yeah, Pam is on the lam in her Mercedes Benz. Benzo. Okay. Mechanism of action. So we have to kind of get into some physiology here. It increases the effect at GABA at inhibitory GABA A receptors. Okay, so if we remember what happens with a neuron and a signal, so remember you have an action potential that comes down the neuron, and then it causes neurotransmitter to be released. Okay, into the synaptic cleft. So the neurotransmitter is released, which you can see there, and then it binds to a receptor, and then that's going to have an effect on the next neuron. Well, in the case of GABA, what it does is it opens a pore and lets chloride in. Okay, and chloride is negatively charged, and remember, to activate a neuron, you have to let sodium in, which is positively charged. You depolarize it. So what happens is when you open it up and you let chloride in, it's going to inhibit that. Okay, so it's going to make it more negative. It's going to make it's what we would say is hyperpolarizes it, but it's going to make it less likely to fire. Okay, so if we think about that, we already kind of start to answer some questions. Well, okay, benzodiazepine, we're talking about a CNS depressant, okay, and we're talking about relieving anxiety. So if we open a channel, which it doesn't directly open the channel, but if we cause this channel to open and let chloride in, that's going to make the next neuron less likely to fire. That's a depressant type of effect. Okay? So what benzodiazepines do is they increase the effect of GABA at these receptors. And we can see here, right there, we can see there's the benzodiazepine binding site. So the benzodiazepine, the actual drug, comes down and binds to that. And then what it does is it makes this open more. Okay, so it makes it open more rapidly, and so more chloride's able to enter the cell, which is going to hyperpolarize that next cell. So we call it an allosteric modulator because it's not an agonist. We'll talk more about what an agonist does. An agonist would actually take the place of GABA, so you wouldn't even need any GABA. In this case, the GABA is still binding, but because you've got this drug on this other site, it's causing it to have more of an effect. Okay, so that's really it. It's not taking the place of GABA. It's just helping the GABA. So we can't really call it an agonist, but it does increase the effect. Although a lot of times you'll see it listed as an agonist. It's just technically not. It's an allosteric modulator because it doesn't directly activate the receptor. And I have a parentheses thing there for some reason. Causes GABA that is present to have more of an effect. So again, it's going to be a CNS depressant because that means that overall, in general, it is going to inhibit neurotransmission in the brain. Okay, it's going to cause those neurons to be more negative, less likely to fire. Okay, so the use of benzodiazepines as an anxiolytic, that's what we're talking about now, so I have that in red. Generalized anxiety disorder, panic disorders, PTSD. It also is used to treat insomnia. Well, that should start to make sense now because we're talking about a CNS depressant. We're making those neurons less likely to fire. Okay, so if you're insomnia, just means you can't sleep. So you take a benzo and it's going to make you tired. It's going to have a sedative or hypnotic effect. Seizure disorders, well, if they're firing too much, well, then it makes sense that you can give them a benzo, and that's going to decrease the firing. Alcohol withdrawal. Okay, I'm going to go back real quick because alcohol. If we look at this, this is kind of fun. Alcohol has its own little binding site. Okay, so alcohol does the same thing. It causes more chloride to go in, and we've always called alcohol kind of a depressant. Well, alcohol has other effects. It increases, it activates some opioid receptors and dopamine receptors and stuff like that, but it does work as a depressant. Okay, so if you have a lot of alcohol, then and you're an alcoholic, then maybe this isn't working as well, and so you can take a benzo and it will activate a different site, so you can stop drinking the alcohol, get rid of that habit, and you won't die, because you can actually die. A severe alcoholic can die from alcohol withdrawal. Okay, muscle spasms. Okay, so again, that's that CNS depression, so central muscle relaxation, induction agents, and anesthesia. So you can see the benzos are kind of shutting things down in general. They tend to be fast acting compared to SSRIs. SSRIs can take weeks to start to work. But benzodiazepines usually work very, very quickly. They're the drugs of choice for short-term treatment of insomnia caused by anxiety, greater margin of safety, and most of them are given orally. Diazepam, lorazepam may be administered IV. So prototype drug, alprazolam, I'm going to go through this pretty quickly because we'll also talk about this later in class. And it's not really all-encompassing anyway. So mechanism of action, we just went through that. Allosteric modulator binds to GABA receptor chloride channel molecule, which intensifies the GABA effects. Therapeutic use for anxiety, generalized anxiety disorder, panic disorder, PTSD. Really, it just depends on what the prescriber, the physician or nurse practitioner, it just depends on what they want to prescribe. what they've had success with, and it also depends on the patient. Now, adverse effects should make sense. These are usually pretty intimidating, but it's CNS depression. So sedation, lightheadedness, ataxia, which means difficulty moving, decreased cognitive function. These all kind of make sense with CNS depression. Anterograde amnesia, kind of the same things, which is difficulty remembering events after the dose. Toxicity. So if you take too much, it can be toxic, and that can cause respiratory depression. Okay, respiratory depression is never good because that's, opioids can do that, cause respiratory depression. You can't breathe and you can die from that. There's also a paradoxical response. Some patients may, paradoxically, instead of having a depressive type of effect, may experience excitation, euphoria, anxiety, rage, and a lot of times that can happen in the elderly just because they may be experiencing some dementia. There may be some brain issues to begin with, and so I'm not saying it only happens if you have brain issues, but it can happen in certain patients that they may actually have the opposite effect. Okay, so some concerns for CNS depressants overall: hypersensitivity. Some people are more sensitive. Use of alcohol and other CNS depressants. So this is kind of a drug-drug interaction, or in the case of alcohol, it can intensify it. We saw that it has its own little binding site, and so alcohol plus a benzo or a barbiturate can really cause some problems. So abuse and dependence is a big problem. And like I said, in the elderly, the drug may work at first, but the patient becomes agitated due to disruption of brain activity. And that's that paradoxical type of effect. It's a paradox. It doesn't make sense. Okay, so those with suicidal potential, possibility of intentional overdose. Now, this isn't to say that it causes suicidal thoughts, which we're going to see with some other drugs. But because they are a depressant, a patient who is already suicidal may take too many, and they can die. So, and of course, those with impaired renal or liver function, and that has to do with the way that it's broken down and excreted. Okay, so we see that with a lot of things. All right, so as quickly as we can, let's talk about barbiturates. Now, let's keep it simple though, because it's kind of the same thing as a benzo, but there's an important difference in the way, in the effect that it has on patients, and that's why they're not used anymore. So you can see here's the benzo binding site that we already talked about. There's the ethanol binding site. These are all different, and they've shown that to be true by isolating these subunits and then figuring out which one they bind. Well, here's the barbiturate binding site. Okay, so it has a slightly different effect. So it has pretty much, well, okay, it has the same effect, it just does it a little bit differently. So it binds to GABA channel and intensifies the effect. Okay, so we saw that with benzos, that ethanol does that too. The only difference, and you don't even really have to know this, but it increases the duration of the opening. So that means it leaves the channel open for a longer period of time. Benzos open, close, just does it a little quicker, which lets a little more in. In the case of barbiturates, it leaves it open, and so you have a lot more chloride that moves in. Okay, which is a little bit more risky. Okay, so that means your therapeutic dose and your lethal dose can sometimes are pretty close, and so that's a greater risk. Barbiturates a lot of times are what they use for when you hear about like date rape drugs, Bill Cosby, and they can kind of sedate people to the point that they can't remember anything. So examples: secobarbital, which is Seconal, pentobarbital, Nembutal, and a lot of these are no longer allowed to be prescribed, or their prescription is very specific. Okay, so powerful CNS depressants, primarily infrequently prescribed as a sedative, hypnotic, or an anesthetic, but also may have anti-seizure effects. Okay, so it kind of makes sense. I mean, you're talking about slowing down the firing rate of neurons. So low doses reduce anxiety, moderate doses promote sleep. Okay, so adverse effects: respiratory depression. Okay, makes sense. Okay, so we're sort of shutting down that medulla, that brainstem region, and so if we shut that down, then breathing can stop. Okay, high risk for psychological and physical dependence. That's another problem, is these can be very addictive, and they were seriously abused back in the 70s. Withdrawal may be fatal. Drug may accumulate in the body due to slow metabolism, and these were largely replaced by benzodiazepines. So these are rarely, if ever, prescribed for treating anxiety or insomnia because of potential for severe adverse effects. Okay, so the reason we talked about barbiturates, because the next group that we're going to talk about are called non-benzodiazepine, non-barbiturate CNS depressants. Okay, so we just saw how they work with that chloride channel and binding at different areas. Well, now we're talking about a drug that has anxiolytic effects but doesn't work in those ways. It doesn't bind to those places. In fact, it may not have an effect on the GABA receptor at all. So examples, this is your prototype, buspirone, it's in red. Buspirone or Buspar, that's a type of a non-benzo, non-barbiturate CNS depressant, okay? So Zolpidem or Ambien is another one, and I recommend you go to Reddit to read about Ambien stories about people sleepwalking and sleep driving and stuff like that. So examples, buspirone, yeah, okay, there we go. So anxiolytics, so these are atypical. And the reason they're atypical, and I'll just jump right to it, is because they're chemically unrelated, and they may have, even though sometimes they have a similar mechanism, it may be a completely different mechanism with completely different adverse effects. So if we think about it, we can say, okay, benzodiazepines, most of them in general have the same adverse effects, the same side effects. But in terms of these atypical anxiolytics, they may have a completely different set of side effects or adverse effects. So they may involve dopamine, serotonin, GABA, or any other system. And they're also structurally different. So if you look at the barbiturates, you can see they all pretty much have the same structure with a few, little things changed on them. I don't even see quickly where this, sulfur. So you can see that they're barely different. Same thing with the benzodiazepines. They all have basically a, the same similar type of structure. But then if you look at these atypicals, the non-benzo, non-barbs, non-barbiturate, you can see that they're very, very different. So they're different structurally, and they're different in terms of their mechanism of action. So kind of along that, so the non-benzodiazepine, non-barbiturate for anxiety, the prototype is buspirone or Buspar. Therapeutic uses: panic disorder, social anxiety, OCD, PTSD. Therapeutic effect is delayed compared to the rapid effect of benzodiazepines. So they have more of a delayed effect. Mechanism of action, the exact mechanism is unknown, but it has effects at serotonin and dopamine receptors. So we don't really have to worry too much about the mechanism of action, simply because it really isn't known. We know more than just what's written here, but that's enough. Adverse effects, mild nausea, and usually when you see that, or oftentimes when you see that, you can just sort of assume that the patient needs to take it with food, or can take it with food if they have nausea. And then it has some predictable things: dizziness, lightheadedness, maybe agitation. I don't think that's necessarily predictable. And then some specific things to this drug. Constipation, so you would advise fiber and fluid. That makes sense. Suicidal ideation. So this means that it can actually cause a patient to kind of have suicidal thoughts. You would monitor for manifestations of depression, suicidal thought. And most adverse effects are self-limiting, so that means that a lot of times these adverse effects will be seen initially, but then they'll kind of go away. And this is not all-encompassing, so this is not probably just what's listed here enough for an exam. So see additional notes, text for more adverse effects, contraindications, drug interactions, administration, that kind of thing. So the last group that we're going to talk about, selective serotonin reuptake inhibitors. Okay, so here's a bunch of them listed here. Paroxetine, it's in red, so that is a prototype for this, for anxiety. Sertraline, Zoloft, escitalopram, which is Lexapro, fluoxetine, Prozac, fluvoxamine, Luvox, and you can see that they usually end in INE, sometimes pram. Okay, so like escitalopram. Okay, so those are your suffixes, your ine or prams. So mechanism of action, blocks the reuptake of serotonin. So remember, if you remember from physiology, when a neurotransmitter is released, okay, so the little action potential comes down, causes neurotransmitter to be released. A neurotransmitter has to leave. It can't just stay there forever. So sometimes it may wander off and get taken up by a glial cell. That's what happens with glutamate. Or it could be broken down enzymatically, which is what happens with acetylcholine, or in the case of serotonin, dopamine, and norepinephrine, it's taken right back up. These are called transporters, reuptake transporters. It's taken right back up into the neuron that just released it. So now we have a possibility of a drug working by blocking that reuptake. So if you block that reuptake, then here are all these serotonin molecule, and 5-HT, just to point that out, 5-HT, it stands for 5-hydroxy tryptophan, 5-hydroxy tyramine. It's made from tyramine. 5-HT stands for, means serotonin, yeah. So you have all these serotonin molecules here, and they're taken back up by the by that neuron through that reuptake. So if you block that, then all of these serotonin molecules just kind of stay in there and they keep activating that receptor. So it increases the effect. Again, it's not an agonist, even though maybe you might see that. It's not an agonist. It's a reuptake inhibitor. It's a reuptake blocker, but it still causes more activation of that receptor. Okay, so SSRIs are selective for serotonin. We're going to see later something called a serotonin norepinephrine reuptake inhibitor. So norepinephrine works the same way. So if you can block both of these, it might have more of an effect, or a different type of effect. I shouldn't say more of an effect, but a different type of effect, and there are antidepressants that do that. Monoamine oxidase inhibitors, you can see that after they're taken up, they're broken down by this molecule, this enzyme called monoamine oxidase, and that is another way of getting rid of it. So if you inhibit that, then you have more of it as well. Now, we're not covering that right now, but you're probably going to see this picture again later. Okay, so the use of SSRIs, these selective serotonin reuptake inhibitors, for whatever reason, leaving that serotonin in the synapse works to relieve depression. Okay, and it's SSRIs. They are the primary drug class used for depression. So that's probably, if you've heard of an SSRI, that might be where you've heard of it. But they also work, and that's what this section is, as an anxiolytic. So generalized anxiety disorder, OCD, obsessive compulsive, panic disorder, social anxiety, severe phobias. They're also sometimes used for bulimia, dissociative disorders, adjustment disorders, lots of different things. Really, it comes down to what is the prescriber trying to do. They can give the drug and see if it works on the patient. Unfortunately, that's a lot of times what happens. Give the drug, see if it works. If it's close, you might change the dosage. If it's not even close, you might change the drug, that kind of thing. So they have a long effective half-life, and this is kind of important. For an SSRI to function, it can take up to 4 weeks. It takes a very long time. Now remember, with benzodiazepines can be very, very quickly. If you need to sedate a patient, you can give them some Ativan. It usually doesn't take very long at all. Okay, so this is SSRI for anxiety. That's what we're talking about. So the prototype drug, the prototype SSRI for anxiety, is paroxetine or Paxil. Mechanism of action: selectively blocks the reuptake of serotonin. So it's an SSRI. Okay, so if you understand that reuptake inhibition, then that's just, I mean, it's kind of in the name, serotonin selective reuptake inhibitor. Primary therapeutic use, I just put anxiety disorders. Okay, so there are a bunch of them. They were listed on the previous page. And depression. So adverse effects: nausea, diaphoresis, which is sweating, tremor, fatigue, drowsiness. Later effects may include sexual dysfunction, so delayed orgasm, delayed ejaculation, decreased sexual interest. And you know, if the patient is experiencing these things, then you might want to look at something else. Weight gain, GI bleeding. This is kind of an important one because, and if you think about it, I don't know if you remember this from clotting in pathophys, but serotonin is part of the serotonin is made by like red blood cells and has an effect on vasodilation. So it is involved in bleeding. Okay, so if a patient is taking, anti-clotting medications or something like that, then that could be a concern. So it's something to monitor. So serotonin syndrome is a big one. So serotonin syndrome is really just when serotonin becomes toxic. There's too much. And we're talking about leaving it in the synapse. So if you have too much in the brain, then that's serotonin toxicity, and it's oftentimes overlooked. It's actually I'm going to say it's more common with MAOIs, which we're going to talk about later, but it can also happen with the SSRIs. And a lot of times it's confused with drug withdrawal or something like that, so you want to have a good drug history to make sure that they're not experiencing serotonin syndrome. So it occurs rapidly within 72 hours of administration, so it's kind of a up kind of a thing, so tremors, agitation, hyperreflexia, fever, so increased temperature, agitation, confusion, and it usually resolves when medication is discontinued. Now there are drugs, there are antagonists that can be used, or you can give a benzodiazepine because these are kind of, I guess, anxiety-ish types of things, tremor, agitation. So a benzo could kind of calm the patient down. But yeah, in general, it resolves when you just remove the medication. Okay, and again, see additional notes. I don't want you to think that this is just all-encompassing and this is all you have to know. There are entire sections that weren't really covered. Nursing administration, things like that. Drug interactions, we didn't talk about that. I will say one thing about drug interactions before I hang up. Drug interactions, when we look at the mechanism of action, so if you look at benzodiazepines and barbiturates, they're really working on the same neurotransmitter system, and so those are going to interact. Now, if you have one that works on GABA and one that works on dopamine or serotonin or something like that, a lot of times you wouldn't call those interacting. So that's one way that drug interactions can take place. So just keep that in mind, and yeah, good luck. Try not to be anxious.